This is Dr. Lori Garner from Nicholls State University, Nursing 591, 691. This is Anxiety and Stress-Related Disorders, Part 2. This lecture will focus on agoraphobia, substance medication-induced anxiety, hoarding disorder, acute stress disorder, and adjustment disorders. With emphasis on the DSM-5 TR criteria, evidence-based treatment, and we will talk about some knowledge checks at the end to make sure you were able to do some clinical reasoning. So the key learning objectives for this lecture are to apply the DSM-5 TR criteria, differentiate similar anxiety-related conditions, develop evidence-based pharmacologic plans, integrate appropriate psychotherapies, and navigate some legal and ethical considerations. So you need to be able to accurately identify diagnostic criteria. Remember I said that DSM-5 TR manual is like the mental health Bible. So you need to be able to pull that criteria. You also need to know the thresholds and functional impairments. That's crucial for making a clinical diagnosis. You should be able to distinguish clinically overlapping anxiety disorders by using the distinguishing features and the temporal relationships to help you be able to form an accurate differential diagnosis. You should be able to select psychotherapeutic modalities, align with the disorders, and be able to understand when would you send your patient to therapy versus when would you use pharmacotherapy. Understanding risks, being able to document correctly, cultural factors, and patients' rights is important for navigating the legal and ethical framework of clinical practice. So this is all important, and we're going to go over that for this lecture. So the DSM-5, of course, provides a foundational framework for diagnosing mental health disorders. You'll hear me say that quite often. By the time you finish my class, you will always say, oh, I have to use this DSM-5 TR. I have to use the DSM-5 TR. Make sure you always use the DSM-5 TR. Skipping any of the overarching principles risks misdiagnosis and suboptimal treatment planning. So duration and criteria are critical. Most anxiety disorders require symptoms to persist for a minimum period, like 6 months. And that helps you to distinguish that disorder from a transient distress. Functional impairment is required, so symptoms must cause clinically significant distress or impairment, not just subjective discomfort. We should rule out substances and medical causes first before assigning a primary anxiety disorder diagnosis. And then, of course, cultural context is important. What is diagnostically significant in one culture may be normal in another one. Comorbidities should be routinely assessed. Anxiety disorders rarely present by themselves. They usually have a friend with them, another disorder. So screening for mood disorders, trauma history, and substance use, that's going to improve your diagnostic accuracy and treatment. So we're going to start off with agoraphobia. Agoraphobia is a type of anxiety disorder characterized by a fear of being in situations where escape could be difficult or embarrassing. Like as simple as going to a grocery store, looking around that grocery store and thinking, I can't get out of here. I'm not going to be able to get out of here. If I try to get out of here, oh my God, what's going to happen? I can't get out of here. So they go into a grocery store, they feel like the walls are closing in on them and they can't get out. So guess what? They're not going back to the grocery store. And that's not even reasonable because grocery stores are so large and there's exits everywhere. But in someone who has agoraphobia, they could be in a superstore Walmart and feel like they cannot get out. Or it could be embarrassing for them. The diagnostic criteria for agoraphobia, according to the DSM-5-TR, is that they have to have a fear or anxiety in at least 2 of the 5 agoraphobic situation categories. So that core fear is that escape would be difficult or help wouldn't be available. If they had, some kind of panic-like situation, like there's not going to be anybody to help them, they can't get out, they're stuck, oh my God, and they really, really get worked up. So they stay inside where they're safe. The situation must reliably provoke fear or anxiety and not just occasionally. So they're thinking anytime they go to the grocery store, anytime they go out of their house, it could be just going outside, they're going to be panicked, something's going to happen, and so they stay in. They're not going to go out. And it's consistent. It's not just, they're going on a date and it only happens if I go on a date. Oh, this only happens if I go to school. I can go to the mall, but if I go to school, I feel like I can't get out. So that's not how it happens. It is pretty much consistent, and it's always wherever they're going, they're going to have this fear. The situations are either actively avoided, so they don't go, they won't go, they're not going out, they're not going to the grocery store, or if they're going, they have a lot of distress about it. So, like mental health patients with agoraphobia, they've got to come in and be seen. So, or they've got to go, maybe they have some medical condition, they have to get to the doctor, they have to go and be seen. They're calling the ambulance, they've got this panic going in, and they are so worked up because they have to go out in public or they have to go to the doctor's office. So they take weeks to mentally prepare themselves that they've got to go sit in this doctor's office and hope that they don't crawl out of their skin or run out of there. So they've already got this anxiety about going to the appointment, and it's weeks in advance. It's not just something that comes on. They start mentally trying to prepare themselves for weeks to go because there is no other option. They have to go. The symptoms must persist for at least 6 months so you can distinguish a true disorder from some kind of acute situational or acute or transient anxiety. And understanding those key criteria are important for properly identifying and treating agoraphobia. So you have to be able to recognize this isn't something that's just happening. It's been going on for over 6 months. These people are not coming out. They get so anxious just thinking about, okay, I've got to go and have my annual exam because I have a history of having some kind of lesion on my cervix. So I've got to go. But now that means I have to go out of my house. So I've got to mentally prepare to go out of my house. So they start preparing themselves weeks in advance to go out of their house because they know that's an appointment they have to go to. So they've got this anxiety, this fear provoked about having to go out. So understanding a full range of triggers is essential for, of course, diagnosing and targeting exposure therapy. So one of the first categories is public transportation. So that's things like buses, trains, subways, and airplanes where they can't easily exit. So they have this intense fear or anxiety about public transportation. Or open spaces. Large areas like parking lots, grocery stores, and bridges. because it feels difficult, like they can't escape from there. So if they're in the supermarket, there's no escape out of the supermarket. If they're in a parking lot, this huge open space, how do I get out of here? How I can't find where I'm supposed to be. Where's my car? I'm stuck. Enclosed spaces like movie theaters, elevators could be another trigger, because now they're on the elevator and they're not going to be able to get off. What am I going to do? Crowds and lines, where escape feels socially or physically constrained, can also make them anxious. And then being outside the home alone, where there's nobody that can help them without a trusted companion, that can amplify their sense of danger. Going with somebody, it's still difficult, it's still very hard, but at least there's somebody who can save them if they need to. But if there's nobody there, they have an increased sense of danger. So knowing these types of situational categories can help patients with agoraphobia, because then exposure therapy is geared towards these situations for them. So agoraphobia is characterized by disproportionate fear of situations that the person perceives as dangerous, even when there's little to no threat. There could be very little actual threat, but this patient perceives it as so dangerous, like going to the grocery store. Patients can have different degrees of insight. Some recognize that their fear is excessive, while others think this is completely rational. Like, I am not going to that grocery store. I don't care what y'all say. Like, I believe this, and they think it is rational. The core maintaining mechanism of agoraphobia is avoidance. So each time a feared situation is avoided, the person experiences relief, a short-term relief. And that reinforces the belief that that situation is truly dangerous, because, whew, I feel better because I didn't have to do that. So I was right. Going to the grocery store, nope, that's not for me. I feel better because I don't have to go. I'm just going to order DoorDash, or I'm just going to have Walmart deliver it. The avoidance fear cycle leads to functional deterioration over time, with some severe, untreated cases resulting in the person becoming entirely housebound and unable to leave without extreme distress or a trusted companion. So you should be able to recognize these key hallmarks to distinguish agoraphobia from some other overlapping anxiety condition, and being able to appropriately treat the patient. Agoraphobia is one of the most prevalent phobic disorders, which affects about 1 to 2% of the population, the adult population. Females are diagnosed with agoraphobia at about twice the rate of males, and that's likely due to some biological and societal factors. Onset of agoraphobia is common in adolescence and early adulthood, so identifying and treating it early is critical. And without proper treatment, agoraphobia tends to follow a chronic worsening course, and it rarely improves spontaneously. So they need treatment for agoraphobia. Recognizing the risk factors is important for early identification and prevention. So one of the risk factors, behavioral inhibition, that's a temperamental trait of withdrawal from novelty and heightened reactivity. It's a robust early predictor of anxiety disorder development. Neuroticism, that is characterized by a high negative affectivity and emotional reactivity. It increases vulnerability to anxiety disorders like agoraphobia. Exposure to adverse childhood events, some type of trauma, neglect, or loss can sensitize the threat detection system, and that increases the lifetime risk of avoidance-based disorders. And of course, a history of panic attacks. Even if not meeting full panic disorder criteria, that increases the risk of developing agoraphobia avoidance as a protective strategy. Some of the differentials for agoraphobia include panic disorder, and that's where they focus on the panic attacks themselves. So being able to distinguish from panic disorder, where fear centers mainly around the panic attack, not escape. So that there's a difference. When people have panic attacks, and we'll go over that, they focus more on that panic versus being able to escape from a place. Differentiating social anxiety disorder. Social anxiety disorder is where fear is driven by social evaluation, not physical entrapment. And then specific in phobias, that's like the fear of some type of discrete object or situation, like, having the blood drawn, seeing a roach, seeing a snake, something like that. Agoraphobia requires two situational categories and a shared escape entrapment theme. And then you have major depressive disorder with withdrawal. That can mimic agoraphobia avoidance. Why? Because, those patients are depressed and they don't want to come out of the house. But it's different because people with agoraphobia have that fear of, remember, entrapment and escape. With major depressive disorder, it's the motivation that is keeping, lack of motivation. They don't want to go out. They have the anhedonia. And then making sure there's you have to rule out medical conditions that could cause dizziness or physical symptoms that's keeping them inside or not going out versus agoraphobia. So remember I said agoraphobia rarely occurs by itself. It usually is hand in hand with some little friend, a different diagnosis, a comorbidity. It often will occur with another condition. And so that's going to increase the complexity of it and its risk. So major depressive disorder is the most common comorbidity. The avoidance, isolation, functional loss of agoraphobia can contribute to depression, which in turn reduces motivation for exposure therapy. PTSD frequently co-occurs with agoraphobia, and that's due to the shared avoidance mechanisms and hyperarousal features. It's important that you assess trauma history in all agoraphobic patients. Then patients may use alcohol or sedatives to manage their agoraphobic anxiety, and so that leads to substance use disorders, and that's going to complicate treatment even further. Other anxiety disorders like panic disorder, social anxiety disorder, generalized anxiety disorder often co-occur with agoraphobia. And each one requires its own treatment considerations. The high rates of comorbidity mean that you're going to need a comprehensive, multi-treatment plan to address all active conditions simultaneously. So agoraphobia can be treated with pharmacological interventions. The first line agents for agoraphobia are SSRIs, like sertraline and escitalopram. These medications have a strong evidence base, and of course they're tolerated really well. Serotonin, norepinephrine reuptake inhibitors, or the SNRIs, particularly the extended release venlafaxine, it's also well supported. That's a very good alternative to SSRIs, especially when the patient also has depression. I have a patient right now with agoraphobia, and they're maxed on venlafaxine, but they are very dependent on that venlafaxine for the comorbid symptoms. Seems to help pretty well. It helps them pretty well. When you prescribe these medications, definitely you need to start low and go slow. So that way you don't have any activation side effects that you can see in patients with anxiety. Advise the patient that the full effect may take 4 to 8 weeks, and don't just stop the medication because they're not seeing any change. They need to give it at least the full 8 weeks would be great. Avoid benzodiazepines because, of course, that can promote avoidance behavior. It can promote dependence and interfere with the effectiveness of any kind of exposure-based psychotherapy. So you don't want to be giving them benzodiazepines. Psychotherapy approaches are the gold standard for treating agoraphobia. So some of the key elements of effective psychotherapy would be psychoeducation. That's explaining the fear avoidance cycle and the rationale for exposure therapy. That helps build trust and motivation. Then you have CBT with graded exposure, the core treatment, systematically confronting those fear situations from least to most anxiety, provoking to get rid of that conditioned fear response that they have. You have interoceptive exposure. That is deliberately inducing fear, bodily sensations. That reduces fear of internal cues that trigger avoidance. Relapse prevention, of course, that is identifying early warning signs and creating action plans, sustains long-term gains after they've had formal treatment. The goal is to help the client gradually overcome their fears, regain their confidence and independence in their daily life. Some legal and ethical considerations. Agoraphobia, it's really complex. So you have to drive the safety standards, because severe agoraphobia or high-dose benzodiazepines can impair the ability for a patient to drive safely. And of course, we have an ethical duty to assess and document driving fitness and counsel patients accordingly. So both the severe agoraphobia and if your patient's on high-dose benzos, they may not be able to drive. Patients with functionally impaired agoraphobia may require disability documentation. So it's important to provide objective documentation based on their criteria. Don't over-certify their symptoms or minimize their symptoms either. And then chronic benzos, of course, that carries a significant liability. You have to document the rationale, make sure you're getting informed consent, and periodically reassess the necessity. Don't just, if your patient's on benzos, don't just prescribe them and just keep giving it to them because they keep showing back up. Do they still need them? And of course, if you're going to discontinue it, you can't just abruptly discontinue them because that's dangerous. It can provoke seizures. So discontinuation has to be monitored, and you have to let the patient know they can't just abruptly stop them either. And then patients must fully understand the evidence base for exposure therapy, including the temporary increase in anxiety that they may experience, and they have to give informed consent before they begin treatment. So that's something, that's like a review, because you guys know about informed consent. You just had that on exam 1. Okay, so we're going to move on to substance medication induced anxiety. So we're going to talk about the diagnostic criteria for substance medication induced according to the DSM-5 TR. The first criteria is that the patient must present with prominent anxiety symptoms, something like panic attacks or generalized anxiety as the dominant clinical feature. The second criteria is that the symptoms must develop during or shortly after substance intoxication or withdrawal, or following exposure to a medication that's known to cause anxiety. The third criteria is that the specific substance or medication involved must have a recognized ability to even produce those anxiety symptoms, either directly or through withdrawal. The fourth criteria is that the symptoms must not be better accounted for by a primary anxiety disorder that preceded the substance use. So there is a sequence, and the history taking is very critical to making the determination if it was substance-induced or some other type of anxiety. Substance-induced anxiety is a common clinical presentation that psych NPs need to be aware of. There's a wide range of recreational and prescribed substances that cause significant anxiety symptoms. And it's important to maintain a broad differential when evaluating new onset anxiety. So let's talk about some of the most common causative agents. We'll start with alcohol withdrawal. So GABAergic disinhibition can lead to tremors, tachycardia, sweating, and intense anxiety, potentially progressing to a medical emergency like delirium tremors. Caffeine intoxication. High doses can produce restlessness, nervousness, insomnia, and palpitations that mimic panic attacks. Cocaine and other stimulants, the sympathomimetic effects like tachycardia and hyperarousal directly induce panic-like states during intoxication, with anxiety often persisting into withdrawal. And then there's cannabis. High THC cannabis commonly precipitates acute anxiety and paranoia, especially in novice users or those who use it quite heavily. And that could lead to panic attacks. And then steroids and thyroid hormones. Some corticosteroids and thyroid hormones both produce anxiety, agitation, and insomnia. And that can be frequently missed if you're not doing a very good medication review. So make sure you are getting a great list of what your patient is taking. So patients who have substance-induced anxiety typically present with panic-like symptoms. So they have the tachycardia, they're really sweaty, they have tremors, their chest is tight, they're short of breath, and they feel like they're losing control or there's some derealization. So they present like someone having a panic attack. The key prognostic feature is that the symptoms resolve with abstinence from the causative substance. So if you take it away within days to weeks, they're feeling better. The panic is gone, the anxiety is gone. However, in some cases, substance-induced anxiety can actually bring about some underlying primary anxiety disorder, like generalized anxiety disorder or panic disorder, that was previously subclinical. So if symptoms persist well beyond the expected clearance period of the substance, it's important to reassess them for some primary anxiety condition. So we'll talk about some of the differentials. The key diagnostic task is establishing clear temporal and pharmacologic relationship between the substance use and the anxiety symptoms. So we have to actively exclude some other potential causes of anxiety, like generalized anxiety disorder. That is characterized by a chronic, pervasive worry, and that is going to predate or is independent of a substance. So this didn't just happen. This is chronic. Generalized anxiety disorder is chronic. Remember, I gave you at the very beginning time frames for anxiety. Panic disorder that's recurrent or unexpected panic with persistent anticipatory anxiety that's different from the substance-induced panic. Of course, hyperthyroidism, that can produce anxiety. Hyperthyroidism can produce anxiety, palpitations, heat intolerance, similar to that of anxiety disorders. So thyroid function tests are important to differentiate between hyperthyroidism and anxiety. And then some medication side effects. Many non-psych meds can cause anxiety as a side effect, so make sure you're doing a very good medication review. The primary goal is to address the underlying substance use disorder first. So of course the patient needs to go, and be detoxed. Withdrawal has to be managed, and you will not do this in a clinic setting, but withdrawal can be managed inpatient. And then of course referral to a substance use disorder treatment, some type of rehab. Hydroxyzine is non-habit forming. That can give some short-term anxiolytic and sedative relief during an acute withdrawal or early abstinence. Benzos should be avoided in patients with active substance use disorders because there's a high potential that they can get addicted. So except in rare cases like alcohol withdrawal, you're going to see benzos used. I think it's lorazepam. You're going to see benzos used for alcohol withdrawal. If you are inpatient in treating someone with alcohol withdrawal, you're not going to do this from a clinic setting. So that is one time where you're going to see these benzos used for a substance, but not for just regular substance use disorder. If the anxiety symptoms persist past the clearance period, then you want to consider using an SSRI if the criteria is met for an SSRI. Substance-induced anxiety, it typically resolves on its own after detox and a period of abstinence, so that's good. Usually within days to weeks, the expected outcome, and that will confirm that it was substance-induced in nature when the patient is no longer having symptoms. Of course, careful clinical monitoring during that period so you can confirm that it was substance-induced cause. Remember though, if the anxiety symptoms persist beyond that period, then there's some other type of anxiety disorder that you need to be looking for. A thorough reevaluation is going to be needed to assess for lifetime anxiety history, age of onset, and symptom presentation during periods of sobriety. And again, the distinction is crucial for determining the appropriate long-term treatment approach, whether that's pharmacotherapy, psychotherapy, or a combination of both. There are some ethical and legal considerations, of course. Prescribing to patients who have anxiety and substance use disorders, you have to be very vigilant, very, very, very vigilant. You have to monitor. Remember, in the case of acute alcohol withdrawal, they may be getting benzodiazepines. Panic attacks with substance-induced anxiety, no, you will not. Controlled substance prescribing for these patients, you have to document and then have a risk-benefit analysis. What's your treatment goals and what's your monitoring plan? Using the prescription monitoring programs, that is excellent. You have to check that before you prescribe any controlled meds. That is a standard of care requirement. So you have to check these prescription monitoring programs. Louisiana does have one. If you have a DEA license, you can check your patients before you prescribe a controlled substance to them. Scheduled medications like benzos and stimulants carry a high risk of diversion in substance use disorder populations. So you're going to do urine screening, pill counts, limited dispensing should be used. Are you going to count their pills in clinic? Nope. But if they're asking for this medication to be filled a week early, 2 weeks early, that's red flags. And then effective management requires you collaborate between other providers like treatment facilities, their primary care provider. You really want to make sure that there's a collaborative treatment plan in place for your patient. Let's go over hoarding disorder. Hoarding disorder is a persistent difficulty discarding or parting with possessions, regardless of their actual value. So it doesn't matter if it's like the tooth floss picks that they've had, even if they've maybe used, they cannot get rid of them. So they may have thousands of them and they can't get rid of them. They cannot possess to get rid of or part with their possessions. So they collect everything. And these people, a lot of them are shoppers. And so they shop and they buy things that they already own, and it just becomes a mountain of things in the home. That difficulty is driven by a perceived need to save items. It could be, there's some perceived sentimental value to them. Like, I flossed my teeth with this pick. Oh my God, and I want to keep it, so I put them in a bucket. And then I flossed my teeth the next day with this pick and I put it in a bucket. And then I keep those. I keep them all. This is the mind of a person who hoards. I keep them all. They have this big bucket of these picks, and they can't throw them away because, well, I've used them all, and they're mine. I'm not going to get rid of them. Or I might need them. There's not that much stuff on it, and I might be able to use it again. What happens if I lose my job and I can't buy these picks, and at least I have these? Or what happens if a hurricane comes and I can't get to the store and I'm out of my picks, even though I have 1,000 of them in the closet, but I'm out, but I have these, so I might be able to use these. I can reuse these. So they're not going to get rid of them. The accumulation of possessions congests and clutters their living areas. So it really, really makes it very difficult for them to even have a path to walk through. And so it compromises what that room is supposed to be used for. So they may have a bedroom that they can't sleep in because there's so much stuff on the bed that they can't even get to their bed. The hoarding behavior causes clinically significant distress or impairment in important areas of functioning, including maintaining a safe living space. These are the key diagnostic criteria for hoarding disorder. So they have to have these criteria. Some of the features: hoarding disorder is characterized by core cognitive and behavioral features that can significantly impact daily functioning. So indecisiveness is a key trait. The patients struggle to make even simple decisions about discarding their items. And they sound like they've got this really good care plan. Okay, it's all mapped out. They're gonna do it. They're gonna do it until it's time to do it, and they can't do it. They can't do it. Like they get anxious about, well, they have all these reasons why they cannot get rid of any of these possessions of theirs. Perfectionism may lead to a fear of making the wrong decision about what they're going to give away, causing avoidance. They don't want to go through everything. They can't, because what if I pick the wrong things to give away? I have one patient who says she's going to give her things away to a charity until it's time to give it away, and then she's got all these reasons why she can't give it to the charity. Avoidance of dealing with clutter creates a vicious cycle of accumulation over time. The DSM-5 TR includes insight specifiers that have important implications for treatment approach. So does the patient have good or fair insight? Do they recognize their hoarding beliefs as problematic, which facilitates engagement in treatment? Do they have poor insight, where they're mostly convinced their beliefs are not problematic, which, that causes even more problems? Or patients with absent insight or delusional beliefs are completely convinced their hoarding is appropriate. And that creates the highest barrier to treatment engagement because they don't even realize, even though, you're doing a telehealth visit with them and they've got to blur out the background, but you can still see there's piles behind them in the background, but they don't have a problem. Or it's somebody else's problem, that's why. So prevalence, of course, it affects about 2 to 6% of the population, more prevalent than we really thought. A lot of times it's underreported. If a patient is coming in to see you in the clinic, you're probably not going to know about this. But if you're doing telehealth and they can't let you see their background and it's all blurred out, but you see stacks of stuff behind them, then you can bring this to light and start talking to them about it. Symptoms typically start in early to mid-adolescence. Of course, they start collecting early, and then they may not show any kind of functional impairment in adolescence, but it starts getting worse with age. Severity consistently increases with age, and by the time these are older adults, the hoarding is so significant, then now there's safety hazards. You can't walk through a home. It's no longer contained to a room. Excuse me. It's now their whole house. It's their kitchen. It's their den. It's their bedroom. Symptoms become more entrenched. Clutter begins to compromise the living space. A lot of time, help seeking remains rare because they have these egocentric features and shame around the behavior, so they don't really want to ask for help. There are some risk factors for hoarding disorder, trauma being a key contributor, adverse life events like bereavement, loss, interpersonal trauma, that all can lead to the use of possessions as symbolic substitutes for security or control or those lost relationships. They may have executive dysfunction, such as deficits in categorization, decision-making, attention, and working memory. Is reliably associated with hoarding disorder, and it explains the persistent difficulty people have with sorting and discarding anything they can. Hoarding, it also tends to have a genetic predisposition where it tends to run in families. So it may be some learned behavior where the child observed parental hoarding, and that can contribute to the transmission among those generations. So understanding those risk factors, that's very important to determine the most appropriate therapeutic treatment. Some differentials, of course, OCD. So you want to differentiate it from OCD, where hoarding may be driven by obsessions or compulsions, and the hoarding is ego dystonic. In psychotic disorders, that accumulation may be driven by delusional beliefs about their possessions. Then in major depressive disorder, it could be functional neglect that resembles hoarding because they're not, they have anhedonia, they're not doing anything, they're not taking care of themselves. Or late onset hoarding behavior in the older population should make you think it could be something neurocognitive like a frontotemporal dementia, and that affects impulse control and judgment. So these are just some of the differentials for hoarding. Of course, it's not isolated either. It's usually got a friend with it, some other comorbidity. It often occurs with some other mental health disorder, most commonly major depressive disorder, which affects over 50% of patients who have hoarding disorder. So depression can reduce motivation for change and make it harder to engage in that decluttering process. It's like a vicious cycle. They're hoarding, and then they look around, they see their environment, they cannot change it, and then now they have depression, and now they can't take care of themselves, so they got this functional impairment, and they're in a vicious cycle. ADHD is another co-occurring condition. The inattention, distractibility, and difficulty sustaining effort associated with ADHD can exacerbate hoarding behaviors. So, but they may need some specific ADHD interventions. Anxiety disorders like GAD and social anxiety, they also commonly occur with hoarding disorder. Um, Again, they have that fear and anxiety about discarding the wrong things. So then it reinforces their hoarding behavior. SSRIs are the most studied pharmacologic option for hoarding disorder. The response rates are consistently lower than for like OCD or some other anxiety disorder. And most patients only achieve like a partial symptom reduction. Fluoxetine, paroxetine, and fluvoxamine have the most supporting data. Fluvoxamine tends to be prescribed more, but fluvoxamine and paroxetine are also good choices. Treatment should include therapy as well. These medications should be considered an adjunct to psychotherapy, not just medication alone. So you've got to get the patient into psychotherapy along with having medication. Venlafaxine, that's shown some benefit in hoarding reduction, especially if the patient also has depression or anxiety. In reality, pharmacologic treatments will only give you a partial benefit at best. They really need to have psychotherapy, and then also the medication. They need a good trial, at least 8 to 12 weeks, and then have some realistic goals with the patient, because this is not something, a pill is not going to fix this. Psychotherapy is the primary evidence-based treatment for hoarding disorder. So psychotherapy for hoarding, like I told you, that is the standard. Cognitive behavioral therapy, that's a specialized and effective treatment approach for hoarding disorder. CBT protocols focus on addressing the core symptoms of hoarding, including acquiring, saving, and discarding behaviors through cognitive restructuring and behavioral experiments. Skills training is an important component, and that targets executive function deficits like categorization, decision making, problem solving, and organizational strategies. And that often precedes the exposure work. Motivational interviewing, that's essential in building the client's motivation for discarding, as many individuals with hoarding disorder have poor insight and ambivalence about change. And then involving family members is important because they often directly are impacted by the hoarding behaviors. Psychoeducation for families can help reduce expressed emotion, which can interfere with treatment engagement and outcomes. So hoarding disorder does have some serious legal and safety implications that psych nurse practitioners need to understand and carefully navigate. Like cluttered environments create real risks. Fire hazards, fall risks, and structural damage. Fire marshals and housing authorities may get involved. Document your safety assessments and any referrals you make, because that's going to create a paper trail. That is important. If a vulnerable adult's living situation becomes unsafe due to hoarding, you may be required to report that to Adult Protective Services. So know the jurisdiction you're living in and the specific reporting thresholds and obligations. And then many hoarding patients lack insight into their condition and they may not understand the risks they're facing. So you may need to conduct or refer for a formal capacity evaluation. And that becomes important if legal interventions, guardianship, or an involuntary placement is considered. Hoarding often tends to eviction cases. You may be asked to provide documentation or testify in housing court. So treat any forensic or legal documentation request with the same care and rigor you'd give to any formal matter. On the bottom line, document carefully, know your reporting obligations, and understand that you might be called upon to support some legal proceedings for patients that are hoarders. So we're going to move on to acute stress disorder. So let's talk about the DSM-5 TR criteria for that. Criteria A is trauma exposure. That emphasizes that exposure can be direct, experiencing the trauma themselves, or indirect, like learning it happened to someone else, or repeated exposure like first responders see. And this is the foundation. Without trauma exposure, you can't diagnose acute stress disorder. So without some type of trauma, they don't have acute stress disorder. Acute stress disorder requires at least 9 symptoms, but they must come from across 5 different clusters. And those clusters are intrusion, negative mood, disassociation, avoidance, and arousal. And we'll go over that a little bit more on the next slide. Disassociation is uniquely prominent in acute stress disorder, and this distinguishes it from PTSD. Don't just count symptoms, make sure they span multiple categories. And then criteria C, symptoms must appear within 3 days and last between 3 days to a month. That's crucial because if symptoms persist beyond a month, you're going into PTSD, not just ASD. So duration is what separates the 2 diagnoses, okay? Duration of time. You need to think about the duration of time. So let's talk about some of those categories that I mentioned. So remember, acute stress disorder requires 9 symptoms drawn from any combination of clusters for that diagnosis. It's more flexible than PTSD, but you have to go through the categories. So intrusion, the trauma keeps breaking through. So like flashbacks, nightmares, unwanted memories, or physical reactions when they're reminded of that event. Negative mood, they may have emotional numbness, inability to feel joy, inability to be satisfied, or if they can't connect with others, or they have a persistent flatness. Disassociation, they feel detached from reality or from themselves. The world seems like dreamlike to them, or it's just unreal. And they may have some gaps in memory about the actual trauma. There's avoidance. There's active efforts to dodge anything connected to the trauma. Thoughts, feelings, people, places, conversations, activities. They avoid anything that's associated with that trauma. Arousal, the nervous system stays in high alert. Sleep problems, irritability, there's constant vigilance. They have trouble focusing. And like I said, they jump at sudden sounds or movements like I demonstrated for PTSD. So there is some flexibility in diagnosis. You can draw from any combination of those 5 areas to reach the 9 symptom threshold, but it's got to come from the 5 areas. Some risk factors for acute stress disorder, female gender, because women are significantly more likely to develop acute stress disorder and PTSD after some type of trauma exposure. And that reflects hormonal differences, neurobiological factors, and social vulnerability. Prior trauma history. So previous trauma essentially sensitizes the nervous system. So each new traumatic exposure compounds that risk. And then cumulative trauma dramatically increases the likelihood of acute stress disorder. High neuroticism, so people with high trait negative affectiveness and emotional reactivity are more vulnerable. They have less built-in resilience and react more intensely to stress. And then the severity of the trauma, the nature, intensity, severe, prolonged, or interpersonal traumas like assault or torture are more likely to trigger ASD than accidental events. So be on the lookout for any kind of peritraumatic dissociation as a strong predictor. So trauma-focused CBT, that is the gold standard evidence-based treatment for acute stress disorder. So trauma-focused CBT is the gold standard. Early intervention, that is so important. Even just 4 to 5 sessions in the weeks after trauma can significantly prevent progression to PTSD. Patients will develop a trauma narrative, so you work through those distorted beliefs about the trauma. Gradually, they'll be able to face some of those avoided reminders and then create a safety plan as well. Remember, early intervention is important. Prazosin is used off-label for trauma-related nightmares and sleep problems. It's an alpha-1 blocker that reduces noradrenergic overactivity that happens during sleep. So it helps with both nightmares and overall sleep quality. So prazosin is very good. That's an old blood pressure medication. Be very cautious about benzos. You guys are going to hear me say that over and over and over in this class. Because while they seem like it would help for acute distress, it can actually interfere with their natural fear extinction and increase the PTSD risk. So only use benzos for severe, specific situations, not as any kind of routine treatment. Acute stress disorder has 2 possible trajectories. Either they're going to recover or they're going to progress to PTSD. So with early evidence-based treatment and support, many patients recover fully within that critical first month. If it's untreated, then acute stress disorder can develop into post-traumatic stress disorder. So about 50% of people who eventually develop PTSD had diagnosable ASD right after the trauma. This makes acute stress disorder one of the strongest predictors for future PTSD. So early intervention isn't just helpful, it's preventive psychiatry. So treating ASD early can actually prevent the development of chronic post-traumatic stress disorder. So if they come in early for treatment, treating them early, they will have much better outcomes. So let's talk about forensic and ethical considerations. Acute stress disorder usually happens in some type of complex situation, like an accident, assault, a workplace injury, or a disaster. So There's usually heightened attention for making sure that documentation is correct. You want to make sure you're writing contemporaneous objective notes on the trauma exposure, the symptom onset, the severity, and how it impacts them, their functional impact. Notes may be subpoenaed and read in court, so be very, very diligent and intentional about the note that you are writing. Treat every clinical note as if it's going to be scrutinized legally. So that should just be a habit that you develop. Treat all your notes as though they may go to court. Avoid any speculation, any emotional language, or assumptions. Stick to the observable facts and patient-reported details. Know your state's specific requirements because they will vary. Common triggers like child abuse, elder abuse, domestic violence. Though, of course, the domestic violence reports varies by jurisdiction. Most states are going to require elder abuse and child abuse to be reported. So you can't just report domestic violence unless you're in a state that allows that. Document what you reported, to whom, when, and why. That's going to protect you and the patient. And then connect those survivors to victim advocacy services, legal aid, victim compensation programs, and of course, community support. That's going to help to improve outcomes. You should make referrals a standard part of your trauma care plan. So for adjustment disorder, let's go into adjustment disorder. That has different criteria, one of them being symptom onset within 3 months. So the key timing requirement, remember, there's different times for different anxiety disorders, so you're going to have to know which one occurs where to be able to distinguish which one when you're doing your diagnosis. Adjustment disorders, the symptoms must happen within 3 months of a stressor. The stressor can be a single event or multiple ongoing stressors. And it's a temporal relationship is essential for diagnosis. It's criteria B, it's an out of proportion distress. So the symptoms are disproportionately severe compared to the actual stressor. You have to consider the context and cultural factors when you assess that proportionality. And what seems minor to one person may be significant to another. So be very culturally sensitive. And then criteria C, once the stressor ends or resolves, the symptoms should improve within 6 months. So that is a critical differentiator from the other disorders. If symptoms persist beyond 6 months after the stressor is resolved, reassess for a primary mood or anxiety disorder. So the 3-month onset and 6-month resolution window are diagnostic anchors for adjustment disorders. The time frames help distinguish adjustment disorders from chronic mental health disorders. You have different subtypes of adjustment disorder. You can have with depressed mood, where they have a low mood, they're tearful, they're hopeless. It doesn't reach major depressive episode threshold, but it still causes significant distress. You may have with anxiety, where with anxiety, they have nervousness, worry, jitteriness, separation anxiety. This is the most common presentation you'll see or that is seen in primary care and in outpatient mental health settings. With mixed anxiety and depressed mood, both emotional symptoms present together, and that often occurs when stressors are ongoing or it involves multiple life domains. With disturbance of conduct, there's behavioral problems like truancy, vandalism, reckless driving. And the patient's maladaptive behavior is their main response to the stressor. With mixed disturbance of emotions and conduct, emotional symptoms plus behavioral combined, that's the most complex presentation. It requires a comprehensive treatment plan, like combining therapy, behavioral interventions, and possibly even medication. Some of the differentials, of course, major depressive disorder. Of course, if a full depressive episode criteria is met, then major depressive disorder takes precedence regardless of whether a stressor is present. So if they meet the criteria for major depressive disorder, you will not diagnose them with adjustment disorder. They will be diagnosed with major depressive disorder. Generalized anxiety disorder, that's diagnosed, of course, when the worry is excessive and pervasive. It's greater than 6 months. It's independent of any kind of specific stressor. Adjustment disorder, anxiety is tied to the stressor, but it's time limited. And then for PTSD and acute stress disorder, if the stressor meets trauma criteria, exposure to the actual or threatened death, injury, or sexual violence, then you must rule out acute stress disorder or PTSD first before considering an adjustment disorder. And then the normal stress response, this is critical, okay? So proportionate, time-limited distress that does not significantly impair functioning is not adjustment disorder. It's normal adaptation. So don't over-pathologize. Don't over-diagnose. You don't have to do that. People will have a normal stress response. So treatment approaches for adjustment disorders. Psychotherapy is the gold standard. Time-limited, focused work is the primary intervention. Multiple modalities are effective. Brief therapy, problem solving, and supportive approaches all have evidence. So brief psychotherapy, that is short-term, focused on the stressor and what it means to the person. Problem-solving therapy is structured, practical approach, help them identify concrete actions they can take. And then, of course, supportive therapy, validate their experience, normalize the reaction, reinforce what's working. This is especially useful early on when people are acutely distressed. Medication is not first line. The focus should be on addressing the stressor and the person's response to it. SSRIs can be considered if symptoms are significant and persistent, especially if mood or anxiety features are prominent. Keep doses very low and short duration, but reassess your patient regularly. Again, avoid benzos. These disorders are temporary and self-limited. There is a real risk of dependence and no need for benzos for adjustment disorders. Some of the ethical and legal considerations, of course, your patient may need letters for disability accommodations or workman's comp. You have to just be objective and make this criteria based only. Don't exaggerate and don't minimize. Document your reasoning clearly. Don't just rubber stamp some requests. Balance patient advocacy with your professional integrity. If it's a young patient, they might need extended deadlines or reduced course load for school or other support. But that's going to require a solid diagnosis and a clear link between the disorder and their academic functioning. So documentation should be very specific about the functional impact in the school setting. Then understand the cultural perception of stress. Out of proportion is culturally relative. What looks excessive in one culture may be completely normal in another. So use cultural humility. Don't assume that your framework is the universal framework. Consider consulting cultural brokers or community members when needed, and avoid pathologizing culturally normative responses to grief or major life changes. Now, here's a little comparative summary that I made. And you guys, your chart looks different, but the information is the same. It just goes over the disorder, the defining feature, and some of the key temporal criteria for it. So you guys, I'm not going to read this to you guys. You guys already have this in your slides. Some clinical pearls. Rule out substances first. Always get a complete substance use history in labs before diagnosing a primary anxiety disorder. Substance-induced anxiety is way more common than we typically recognize in practice. Assess suicide risk every time. Anxiety disorders, especially when paired with depression or substance use, carry real suicide risk. Make risk assessment part of every visit, not just your initial evaluation. Avoid long-term benzos, because chronic benzos, that use leads to avoidance behaviors, dependence, cognitive dulling, and falls. SSRIs and evidence-based psychotherapy are the gold standard for long-term management. And then document functional impairment. You need to clearly document any impairment for your diagnosis, disability forms, legal cases, and insurance. Be specific about actual limitations in work, social life, and daily activities. Okay, so these, you guys have this. It may be a little bit more difficult to read, but this is just giving you a chance to apply what you've learned from this lecture to a real clinical scenario. So using a structured framework with 3 questions to guide your thinking. So I'd have to give you a case to do this on, and I don't have that case with me right now. I will put a case slide before you. I'll put a case slide with your slide so you can read through the case and then use the questions to work through. But I do have some other questions for you. We're going to do some knowledge check questions. So question number 1. A 28-year-old woman avoids grocery stores, public transportation, and movie theaters because she fears she will not be able to escape if she develops panic symptoms. She has avoided these situations for 8 months. She denies fear of negative evaluation by others. What is the most likely diagnosis? Is it A, panic disorder, B, social anxiety disorder, C, agoraphobia, or D, specific phobia? And you do have these questions on your slides. No, I do not give the answers. I do not give the correct answers. So I do not ever go over these correct answers. You might see them again. So, but I don't go over them. Okay, question number 2. A 40-year-old man develops panic symptoms 24 hours after stopping heavy chronic alcohol use. Symptoms include tremor, tachycardia, and intense anxiety. What is the most likely diagnosis? Is it A, panic disorder, B, acute stress disorder, C, substance-induced anxiety disorder, or D, generalized anxiety disorder? Question 3. Which feature most reliably differentiates hoarding disorder from OCD? Would it be anxiety? Would it be B, repetitive behaviors? C, egocentric beliefs about possessions? Or D, SSRI response? Question 4. A patient with dissociation, recurrent nightmares, and hypervigilance beginning 5 days after a severe car accident. They have no prior psychiatric history. What is the most likely diagnosis? Would it be A, PTSD, B, acute stress disorder, C, adjustment disorder, or D, generalized anxiety disorder? Question 5. A college student develops significant anxiety and sleep impairment 1 month after failing a major exam. Symptoms cause functional distress but do not meet criteria for GAD. There is no trauma history. the most likely diagnosis? A, generalized anxiety disorder. B, adjustment disorder with anxiety. C, panic disorder. Or D, acute stress disorder. Okay, that's all, folks. That's the end of this. It will be in the course. I think if you went straight through, your brain has officially earned a snack break. If you even pause, you still have earned a snack break. Now, go and prepare to ace the exam. You guys have what you need. Keep listening, and if you're not listening, just keep reading. You don't have to listen to these. You can read the information, use your course calendar, and you will do just fine.